Today we would discuss about fetal echocardiography and fetal atrial arrhythmia. That's the commonest arrhythmia what we have, but I've categorized it to fetal bradyarrhythmia because sometimes ectopics can produce bradyarrhythmia rather than causing tachyarrhythmia. Really so? Can it do that? Yes. There is something called blocked atrial ectopics. So let's dive into and see what are these blocked atrial ectopics. I had a good idea, in fact, that if you subscribe the channel and as and when I would post something new, you obviously would be notified as accordingly. So I'm going to discuss this in 3-4 heads. One head is that let me discuss with you first the basics of atrial ectopics and blocked atrial ectopics to be particular. Then second would be how do we diagnose these in the fetal echo on an M mode. Third is that what is the differential diagnosis and mimics of this atrial ectopics. Third would be once we've recognized, made our judgment, what is the treatment we are going to offer to the patient, right? So now first is atrial ectopics. That's a normal sinus rhythm. You see it starts from the sinus node, spreads over all the atria, and then through the AV nodes goes, there is a delay here, and goes into the ventricle. That's something which is very, very basic and produces PQRS components. But many a times the atrial ectopics can arise from a different focus and they come premature. See, prematurity is the hallmark of atrial ectopics, and they pass through the AV node and they produce a premature beat, what we call as a premature atrial contraction, supraventricular atrial ectopic or atrial ectopic. They're all synonymous to each other. We have something called a ladder diagram. I think I have shown that in the arrhythmias, my YouTube video. It will be a good idea to go through that video also on a basics of M mode. Then we describe atria, that's a sinus node. From there is atrial conduction, there is a delay in the AV node and ventricle. In the normal sinus rhythm, everything happens normally. AV node from SA node, atria to AV node to ventricle. And when we have an atrial ectopic, there is an ectopic focus which fires prematurely, then the sinus beat, and then it is conducted down and it produces an abnormal P wave because it's an ectopic and QRS complex. That's an atrial ectopic classic. Now I'm going to tell you another type of atrial ectopic. Yes, so that's a usual atrial ectopic. You see a P wave here, you see a QRS, but many a time you see a P wave but you don't see a QRS complex. Yes, so these are called blocked atrial ectopics. They got blocked at the AV node. This does not mean that AV node is diseased, because atrial ectopics are happening so prematurely that AV node has not come out of the refractory period. So that's why it does not conduct it forward. So blocked atrial ectopic do not mean that AV node is diseased. Okay. So this is the ladder diagram. When you have an atrial ectopic, in the previous one you saw it was conducted to the ventricle, but not here, not in this one. It gets blocked in the AV node. You just get an atrial activity, don't get any ventricular activity. So that is what is going to cause a lot of confusion. So how do we diagnose atrial ectopics and blocked atrial ectopics when we're doing a fetal echo? In a normal atrial ectopic, you see you have a atrial ectopic conducted through the AV node and the ventricular contraction. So premature ventricular contraction following an atrial contraction indicates that the atrial ectopic was conducted right through and through to the ventricle. But now look at this. Now atrial contraction, another atrial contraction, and you don't get a subsequent ventricular contraction, which means that it did not find its path away through the AV node to reach the ventricle. So these are called blocked atrial ectopics on fetal echo M mode. That's how you diagnose. It's very, very important, because I'm going to tell you at the end of my slide the differential diagnosis. So that is where the importance comes. Now you look at the blocked atrial ectopics. This is the blocked atrial ectopic. This is the normal beat. Atrial ectopic does not have a ventricular beat. Normal ectopic, not conducted, normal. And now see here, it is coming in bigeminy. Yes, one normal, one ectopic, one normal, one ectopic. So doesn't it give a feeling of a 2:1 block? So that's my next discussion. The discussion here is a differential diagnosis. It's a very, very critically important differential diagnosis, that is it 2:1 conduction or is it a blocked atrial ectopic? So the red one, A wave is A beat, is the atrial beat ectopic or a normal 2:1, which is the two atrial beats and one is conducted. This is very, very important differential diagnosis. Many a times I do get patients where they have a slow ventricular rate and you notice the atrial rate and it is misdiagnosed as a complete heart block, right? I'm going to tell you that this is not a complete heart block and how to differentiate between the two. Now, very first thing, as I told you, that atrial ectopic means premature. So it's a premature beat. They don't come regularly. They come in pairs. So the premature beat is closer to the previous beat, and there is a compensatory gap between the second beat which comes, right? So this gives you an important clue that this is a blocked atrial ectopic and coming in bigeminy and not 2:1 block. While the 2:1 block, it would come absolutely regular. Done. So once you see there is a atrial ectopic which is blocked and coming in bigeminy, and you know this is not a 2:1 block, you should follow the patient, because majority of the patients would resolve in 1 hour, 1 day, 2 day, or it may take little longer also to settle. So now the difference between blocked atrial ectopic and 2:1 AV block. There is an important difference between the two. The SVEs, whether blocked atrial ectopic or conducted, are transitory. They are going to disappear after some time and they are benign. And the incidence of supraventricular tachycardia is higher, so you need to have little more caution than regular SVEs, where the incidence of SVT is about 2%. The important difference is, God forbid, if it is 2:AV block, this can rapidly progress into a complete heart block. Once it goes into complete heart block, your steroids, your IVGs, nothing works, right? So we need to prevent this 2:1 going to the complete heart block. And how can we do that? With steroids and other drugs, correct? So this is a very, very important way you should differentiate between the two. So differential becomes very important, and that is where the treatment becomes important. Now, if there is a confusion still, because many a times you may not be able to see that irregularity or beats coming in a couplet kind of format. So if there is a confusion, you obviously have to wait and call the patient next day, that the atrial ectopics would disappear, complete heart block would not, or 2:1 would not. But in the day, let us presume that patient might develop a complete heart block. So we are having that unsafe window of 24 hours. So what I normally do, I start the steroids with the patient, send the samples for autoimmune heart block, that is anti-RO and anti-LA antibodies. When you get the anti-RO, anti-LA antibodies which are normal, that means this is not an autoimmune condition, it would not respond to steroids. We stop the steroids and follow up the patient till it becomes a normal sinus rhythm. I hope this is going to be very, very useful to you, because this is seriously not a very uncommon situation. We every now and then, I think 1 or 2 patients in a month, we do see this kind of 2:1 conduction system, where we need to differentiate between AV block versus a blocked atrial ectopics. Now, I think it's a good idea to subscribe the channel so that you keep seeing what I am sending you and you are getting notified. And I wish you happy learning.